Good evening, everyone. First of all, I would like to welcome everyone who is present here for the first session of webinar from the Cognition Medicos and in association with MacFace. So, today's topic for the webinar, as we all know, maxillofacial trauma. So, first of all, I would like to introduce our chief guest for this session. So, Dr. Saha, Sir, Dr. Anirban Sarkar Sir, Dr. Suravi Sarkar Sir, Ma'am, and Anagh, am I audible to everyone? Hello, Anagh?
Yes.
Okay. And Dr. Mukesh Chhetri Sir. So, welcome you all to this webinar, and I would like to thank everyone on behalf of Team Cognition Medicos for participating in this webinar. So, as we all know, maxillofacial trauma is a huge topic. So, what we have done, we have decided to just break this webinar into 4 modules, okay? And this every Thursday of this July, we will be taking a part. So, today's part will be the preliminaries of maxillofacial trauma. And I'm not going into the details of the topic because we have the panel of experts for this. And one more thing to add that, we have designed something more for this, to make it more interesting and introductory one. So if those who are attending this webinar, you have to just go for a small test after this session, not today, obviously. So those who will be getting 75%, a particular percentile, those will be allowed to attend the next webinar session. So I hope that everyone will enlighten themselves and enrich themselves with the knowledge. So let us have some good words from Dr. Suravi Sarkar, ma'am. Ma'am, to you.
Hello, can you hear me?
Yes, ma'am, you're audible.
Okay, hi everybody, this is Dr. Suravi Sarkar. I am attached to North Bengal Medical College Trauma Center, and I will just be giving an introduction to today's session and the sessions that are to continue from next week on. So today's, we have a series of 4 lectures that are scheduled for this month, that is every Thursday like you said. These lectures will be based on facial trauma, maxillofacial trauma. So we have 4 lectures. Today's lectures will be on the primary management of facial trauma, the preliminaries of it, and the next 3 lectures will be on mandibular trauma and the management of it, that is the lower face trauma. Then the next lecture will be on the mid face trauma and management of it. And the 4th lecture will be the management and discussion on upper face trauma. So these are the 4 lectures. All these lectures will have a examination that you have to take at the end of it. So today's lecture, after today's lecture, we do not have the examination today. We'll have it in the next session. That is the next week. So every Thursday we are going to have this lecture. First we are going to have the test next week, and then we are going to have the next lecture. So now about the examination, there are going to be 2 kinds of tests. One is since this is an interactive session, we are going to have a viva voce sort of interactive question answer session along the course of the lecture daily. And the other test, that is the 20 MCQs that you have to answer, that is going to be held the next day. So after today's lecture, once you are done with today's lecture, you have to take the test on today's lecture the next day before the start of the next lecture. So the questions will be MCQ questions, and there will be 20 of them. So you have to jot these answers down when we show the questions on the screen, and the questions will be marked, numbered, that is 1 to 20, and you have to jot these down. And the answering scheme of these questions will be like, you will be given an MCQ portal in which you have to upload the answers. And this portal will be open, valid for only 15 minutes every time you log in. So once you log in, it will be valid for only 15 minutes. In this time, you have to put your answers in, whatever you have jotted down. and 15 minutes is 5 minutes. So after 15 minutes, this portal will close. So that is how it is made. So the ones who are taking the test and who are getting a score of 75%, and that is all the four lectures together. At the end of the fourth lecture, we will be giving out the marks. So the people who score above 75% will be taken in as members of MaxVac, and they will get the membership for this. So uh, after the fourth lecture, it will be given the results will be published later. So that's how the examination and the lectures go. And we'll come to the membership, how the membership goes in MaxFac. So all these lectures and the exams that we are taking, it is we are searching for we are trying to get a increase in competency of the people who are members of MaxFac, because we want people who are interested in doing the work, who can do the work, maintaining the protocols and the correct principles of that we want to follow in the organization. So that is why we have these bases of exams and scores and all these the rules and regulations that we will be giving forward even in the course of time. Now, talking about membership, there are two kinds of membership that we have. One is the student membership, and the other is the professional membership. So, since we have a lot of people here who are students, that is BDS and MDS students, so the membership for you guys is like you have it's chargeable membership, of course. So we have the membership of 1,500 rupees for 2 years, which is renewable after 2 years. And after 2 years, in that current period of time, whatever the membership fees will be, that will be the renewable charges. So it's 1,500 now, and you will be renewing it after 2 years. And then there is a professional membership for professionals who are already graduates, MBBS and BDS graduates, and are probably doing their MDS or have passed their MDS, MS, MCH, or MD. So this is for professionals. It is the membership fees for them is 3,000 rupees for a period of 3 years, and that is also renewable after 3 years. And the charges will be applicable according to the current charges of the membership at that time. So since this is a COVID crisis that we are facing this year, all the charges of membership are levied for this year. We will not be taking charges for this year. This is especially because of the COVID crisis, and for this year it is going to be a free membership. So everybody who qualifies the examination and gets a score of 75% and above will be members of MaxVac organization and will be doing all our courses with us together. Also, all the members who are who are getting enrolled into a MaxVac organization, there are many benefits of this. First of all, we'll have a lot of educational and hands-on courses that we'll be conducting in the course of the year. So all these courses are, most of the courses that are free courses are for all the members of the MaxVac organization. And there will be some payable courses that many others can also attend. But for the members, this will be at half the cost, that is 50% of the enrolling charges for those courses. So these courses will include many educational and hands-on courses, surgical courses. So that is a benefit that we have. And also all the members who are there who are interested in speaking on topics regarding craniofacial surgery, regarding maxillofacial surgery, reconstructive surgery, or any head and neck surgery, and are keen on giving their innovative thoughts and ideas, or want to speak on some topic that they are interested in, they are most welcome to use our platform and speak to us and share their thoughts with everybody here in the MaxVac organization. So this is about the membership. More details will be given in written formats and will be circulated for everybody to understand it in a better manner. And then we'll talk about the fellowship that we are offering here in MaxVac. So the fellowship course was supposed to start last year actually, but because of COVID, this pandemic, a lot of things have been in a hodgepodge and we could not get along with it so well. But the thing is, we are planning to start the fellowship course in craniofacial surgery somewhat around next year in the month of April or May. And so the fellowship is in craniofacial surgery, and there will be 5 fellows taken every year. And these fellows have to will be selected on the basis of an examination that will include a viva voce and a written MCQ examination. So these details will be furnished later, because as of now it is in a halt, and we will be starting with it soon in the end of this year. And fellowship. The program is based in Siliguri and Calcutta. So we will be telling about the details of the curriculum of the course, and where what will be held, in which place, which hospitals. Everything will be given in a brochure that will be published later and circulated among everybody. So the minimum qualification for this fellowship is that you have to be a graduate, that is a BDS or an MBBS graduate, and others who are MDS, MS, MCH, or MD, who are interested in doing the fellowship, are also welcome to sit for the examination, and will be selected on the basis of the results of the examination. The top 5 will be selected for the fellowship course. So that is all about the membership and the fellowship courses that we have here in MaxFac for now, and all the things that I had to share. And so all these things that we have about, like I said, for the exams and the selective thing that we are holding for selection of members and all, is to increase our competency, like I said. So we want people who are really interested and who would be able to keep up with our standards and protocols of work. And that's all for now. I think very welcome to MaxFac organization. I hope you enjoy your first lecture today and continue with the course. Okay? Thank you. Thank you, Sayantan.
Thank you, ma'am. I will just request Dr. Chhetri sir to give some valuable words. Sir, I think your mic is not turned on. Yes, sir, you're audible.
Hello.
Yes, sir, you're audible.
Okay, I welcome you all to this first lecture, which will be as the introduction to the management of facial trauma as well as craniofacial injuries, and I'll be demonstrating the various trauma aspects later on. Hello.
Yes, sir, you're audible.
Okay, so basically we'll be starting this as Dr. Suravi left. We'll be starting about these lectures. There will be a series of 4 lectures, and this is the first of it. I hope you all enjoy this lecture. Thank you.
Thank you, sir. Now I just request Dr. Anirban's focus, sir, to give his valuable words for this webinar. Sir, I think your mic is not turned on. That's why you are not audible.
Yeah, now am I audible right now?
Yes, sir, you are audible.
Okay. Hello everyone, on behalf of MaxFac organization, I am privileged to see so many participants amongst us, and I welcome you all with open heart. And the first thing which I want to do is take this opportunity of wishing all the doctors here, the lifesavers, a very happy Doctors Day, which was last day. Today I am here just to introduce you all to what is MaxFac. MaxFac is an organization where we are trying to just learn. We are here to learn, and we have got eminent teachers amongst us. Dr. Saikat, whose initiative of MaxFac, he is a wonderful teacher, I have been in a learning throughout learning process from him, and we hope to learn more, and we hope to learn from our other participants also. The ones who are here, you can come ahead and present your cases, your discussions, any doubts, any queries you can put forward so that we can discuss. This vision of MaxFact was developed by Dr. Saikat, and his vision was to make us more competent in our practice. He wanted that he always used to say me, like, Anirban, there are many patients who are poor, who are leaving this places, nearby places and going to South India for practice or somewhere else for practice. Why can't we be competent and do this job over here? I said, sir, the only key is we should know how to do those things. We should learn. And he is one person who always worked on that. He likes teaching, and I think we're gonna have a splendid time in learning oral maxillofacial surgery of head and neck regions over here. And I wish all the best to everyone for joining in here. And I will ask everyone to pour in your efforts and spread our MaxFact name to more of your friends so that more and more days go, we get more participants so that we can spread the valuable knowledge of head and neck regions, surgeries, and we can help more and more patients who are nearby to us so that they don't have to take this pain of not getting the treatment in their places and they're going to traveling to different places. This is the only reason we are here to learn more. I wish all the best to everyone, and over to the host. Thank you.
Thank you, sir. Now Dr. Shulkar sir will take us to a beautiful journey in the preliminaries of maxillofacial trauma. To you, sir.
Thank you, Sayantan, and welcome everybody. I hope I am audible to everyone.
Yes, sir, you are.
Yeah, that's fine. So, everyone has introduced what MaxFact is. MaxFact is actually an organization of you all who are actually seeing. Actually, everyone who comes to MaxFact stays with MaxFact. There is a reason, because we are a particular core team which are actually dedicated in spreading a knowledge about head and neck surgeries to at least we have been doing for the eastern part of India. We go and train people at various parts of eastern India, like Assam, West Bengal, then Meghalaya, Manipur, Mizoram. These areas are covered by us. So right now we have been doing that way. But anyway, I'll not talk about what MaxFact is because we'll be saying more about the MaxFacts in a written format also, and we'll be providing other information services later on after you complete the course. That will be quite clear to you later on. But right now, I know you all have been waiting for a pretty long time, listening to so many one of us. So let's start with the presentation.
Yes.
I hope. Is it visible?
No, sir, not yet.
I hope it's visible now.
Yes, sir, now it's visible.
Thank you. Well, maxillofacial trauma is quite a big topic to handle, and so what I have decided is to divide this particular the zoner of the topic into 4 different parts. The first part is we'll talk trauma in general. What happens in a trauma, and how many kinds of trauma that can happen in the whole body, especially in reference to the face and head and neck region, and what are the core management strategies. Basically, what I will be saying is a combination of BLS, ATLS, and ACLS. These are the basic building blocks of any emergency situation. So when we say that it's a trauma, then what we mean? It's, after all, it's a physical force that results due to an injury that we all know. But this definition should be in your mind. What is trauma? A physical force, not a mental force. one can say that I feel so traumatic. Okay, that's a feeling, that's a different thing. But as far as the medical term of trauma, it's a physical force that results in injury. This definition is very important to remember. Now remember, when we say force, force, we always recollect things that happened in the past when we used to learn physics. So force means the big F. And can you just appreciate this kind of equation that we learned during our childhood days? Yes, it is the kinetic energy, which is the half the mass of and the volume, the velocity square. That means a person is having a higher velocity hit is going to have a lot of kinetic energy. In case a person having a greater mass will also have a kinetic energy, but not more than the impact of a more velocity. So this is what I wanted to stress. So the velocity of impact is very, very important. So what does kinetic energy mean? It means the degree of force. What is the how much the force of impact has been. You know, depending on this, injury that the person sustains, there are the force can be of different types. But that means the injury that is caused can be due to different areas. One is the area in which the injury is taking place. For example, what do you think that if a guy gets a blow on his chin, and if a guy who gets a blow on his forehead with the same kinetic energy, which will be more disastrous? Well, you might be thinking, some might be thinking chin, some might be thinking the forehead. Well, we'll see what exactly happens later on as we will strengthen the understanding about injury. Then the resistance of the force, which is also whether there is a resulting movement of the head or head of the soft tissue. That which means, for example, if something has hit your body, someone's body, so it and there is no movement within the soft tissue structures or the brain that is sitting with it inside, then the injury will be quite less. But what do you think that if the impact is so much that the soft tissues and the structures inside it, they start to move, or there has been a shear or wear kind of movement, shearing movement, then the injury will be more. And also depends on the angulation of the strike. That means a perpendicular force will always cause a serious injury rather than a inclined force. This is a question. Before we start, we have to see something. Can anybody tell me what is this? Anyone? Chantan, please. Someone please type it, and Chantan will be reading it out so that I'll be able to make out what others are typing.
Okay.
Any idea?
Okay, all participants, just if you can recognize.
Is it some kind? Is it some kind of instrument that is used to detect trauma? Use your brains, use your thought, use your perceptions. I know it will be quite difficult for you. It is not. This is the first. This is the first recording device of sound. The sound I am talking right now. This device recorded sound. You can see the big dome-like structure is made out of plaster of Paris. And over here, can you see my cursor, everybody?
Yes, sir. Yes, sir.
Is my cursor visible?
Yes, sir.
This is the dome. And someone would speak from this side of the dome. And the other side, there is a vibrating, there is a needle out here. And there is a paper roll. Can you see? This paper roll would record whatever the frequency that is coming. And it was actually called a phonogram. And it was the main inventor was Martin. Will use a French, but I'm not going to go into a detailed history of it. And it looked like this. The paper looked like this. Whenever the needle moved, whenever someone moved, the paper looked like this. So this was the first device that was recording sound But at that time, there was no device that could replicate or reproduce this thing so that it is audible to us. Later on, in the early 90s, various universities, they tried to decrypt these particular things, and lots of beautiful noises of the old past could be heard. They actually simulated that thing. So this is actually the original look. This is a prototype. You can see the rope. Someone you would used to speak from here. And nowadays, gradually things proceeded. We started recording things on a gramophone record. Record, and record. This is the main goal of thing. So recording a patient's data is very important. So we have been struggling with sound, but also in medical science, we have to record data. Why it's important? Because suppose by recording data, where there are many scales, there are many protocols, there are many assessments which are done based on those records that we gather. Targeting a care, for targeting care, we go for a Glasgow Coma scale. And if you want to predict the outcome of an injury, then we use two types of score. One is abbreviated injury scale and injury severity score. Then for assessing a critically injured patient, who's critically injured, for assessing, we use Apache. So the objective of scoring can be we target what is the target care, and next is prediction, and third is the assessing. Assessment is very important. So for these reasons, it's very important to record a patient's data. Whatever patients come to you, have to record it. Another question is, what are the types of maxillofacial injuries that a person faces? That are facial injuries in one sense. The six sigmas, like it's called assaults, fall, industrial injuries, RTAs, sports injuries, war injuries. These are six important things. Well, there are other categories like chemical injuries are there, but that comes under industrial injuries. And sometimes, we get nuclear injuries. Though I have never seen a case, I have never got that. Rather, I'm very fortunate I haven't seen a nuclear injury case, because I don't want nuclear things to pop up right now. It's COVID. So we have to get a brief understanding what trauma looks like. But now, I'm going to show you the step-by-step order in which we are going to think about how a brain should think when we have a trauma patient in front of us. There are various scenarios. Some of you who are already practicing might be finding that you work in a corporate hospital or a more high-end hospitals or tertiary centers. Management at tertiary center is different. Management at the primary center is different. Management at the scenario on the field is also different. So the goal is to give a concept to where to start from and how to organize ourselves. So before everything, we must know what is the epidemiology of this thing in an Indian scenario, because most of us will be dealing in Indian scenario. I know some of you, maybe so many of you might be going abroad, but for the current thing, we are talking about a survey in the 2002. I'm giving a survey. The survey remains more or less the same, but maybe differing 5 to 10% every year. So this is the amount of injury that we get to see. People die. 1 billion die in India every year, and the alcohol is one of the reasons. Violence, falls, and most importantly is the road traffic accident, which is 60%. Quite high, right? So drive carefully and inspire others to drive carefully. Well, reason for the death becomes the severe head injury. When severe head people who are sustain severe head injuries, they around go the highest percent. So it's very important that we understand head injury also, even if you're not a stream of neurosurgery, even if you're an ENT surgeon or a plastic surgeon or a general surgeon, we all must know that how to take over a patient because of a trauma patient with a head injury, because every decision that we'll make will count, because the people with moderate head injury has a 5.6% mortality rate. So there's a high rate that chances that you can make the patient survive. So you don't wait for the you waste your time and let the patient die, right? And people who have skull bone fractures, some way or the other, at least at around 40%, they happen to die. This is quite a high mortality rate. Skull bone fractures give a particular impression that the amount of trauma, it gives the degree of trauma that happens. Because skull bones will fracture only when the degree of trauma is good enough to break it and just cause a severe injury, internal injury to the brain. As I told you, MVI, firearms related falls, these are the reasons for lots of traumas that we see. But over here, we can see the three important points of death that occur in the. So first is that the early death.
Okay, sir. Excuse me, sir. Sir, actually, I think, sir, there is some issue from your.
Yes.
Yes, sir. Sorry, sir, to interrupt. Sir, I think there is some network issue from your side. Like your voice is cracking and the video is pausing for a moment. If you can just kindly check.
Okay. But it's doing fine. I think it's doing fine. Can you see me?
Yes, sir. Now
See my screen?
Yes, sir. Yes, sir. Yes. Yes, sir. Now it's okay.
Is it okay?
Yes, sir. Yes.
So, as I was saying, it was all about early death, immediate death, and late death. So, cells, hearts, lungs, or major disruption of body cavities, and the person happens to die and get category. Then the next category of people who are in early death, these people somehow they manage to reach the hospital but happens to die within 24 hours from the impact. Because probably they had a spinal trauma, they had other injuries. Somehow during the transportation or the wasting of the time, they lose their life. And the late death happens to weeks and months after injury. It's the days and weeks after injury it can happen. There's three categories of death that happen from a trauma. So the idea behind everything is initial assessment. That you have to assess and don't sleep. For God's sake, don't be lazy. Act prompt. This is very important. And we have to prioritize things. What do you think? Whenever a patient arrives with for a trauma, will you be talking to your girlfriend? I hope not. You have to give it a priority, right? We initialize all the steps, right? Now there should be an order of priority. That we must know how to prioritize things. I hope it's clear. First we A, B, C, D, E. Well, these are the airway, breathing, circulation, stability, and environment, and these priorities change from time to time. Initially it was said by ACLS or ATLS, they say A, B, C, D, E was the criteria. Then it was CAB. Then was the BACs. In that unit, every time these protocols are reviewed and they are changed. So I'll explain to you how to manage. But the idea behind this is how you will manage an airway, how are you going to manage breathing, how are you going to manage circulation, disability, and what does environment mean. So history is very important. What kind of history are you going to take? What was your grandfather's name? No. There was a witness loss of consciousness. You have to get a witness. So how much time was involved? Was there a lucid interval? Has there been deterioration in the patient's mental status? You have to see the check for the mental status. Ask the anyone on the roadside. And maybe you can ask the policeman. Maybe any person who is bringing the patient to you. Also ask for seizures, a single event that has happened after injury. And also whether any assist spinal cord trauma, look for it and ask when whether there was any kind of pain, exorbitant pain along the spine. All these things histories will count and always note down. Please note it. That's very important. Noting is very important. So we need to evaluate a patient so that we are able to understand when to intervene and how to intervene and whom to intervene. So we have to go for a certain neurological examination. Before we start with A, B, C, D, E's. This is just a recap for those students who are actually newcomers. It's not for the person who are already passed out or already practicing. As I go with this one for the newcomers. For the mental status, levels of for this thing, we are going to assess the Glasgow Coma scale, and there is called a SMS scale, SMS scale, that's called simplified motor scale. Then AVPU, ACDU. Don't worry about these terms if you don't know. This will be clarified later. Then I'll go for the sensation, touch, vibratory, proprioceptive, and also the proprioceptions and pain things. You look for it. Then cranial nerves, look for the individual cranial nerve functions. Motor functions should always be tested. Cerebral functions, they are very important in trauma. You have to see for those, and reflexes, deep tendon reflexes should always be examined. So these are the part of the neurological examination, which is just a recap exactly what is so important in trauma, so that people who are already studied, who already know, they could recap these terminologies. But how do we judge? To
Hello,
how to
sir.
record, how to infer from the thing.
Hello, sir. Sir, your video is paused, sir. And the presentation too, sir.
Who does not agree with me, please? Glasgow Coma scale was discovered by Dr. Glasgow. Who does not agree? Sayantan, please come up if someone is answering.
Yes. Students, those who want to answer, please write in the comment section. Do you agree with that? Glasgow Coma scale was discovered by Dr. Glasgow. If yes, then write yes. If no, then write no.
No. This is the answer. And I would appreciate all those people who did not agree with me, because it was actually discovered by two very important.
Hello, sir. Can you hear me? Hello, sir. Can you hear me? Hello, sir. I think, sir, there is some network issue from your side. So, sir, I will just request you to just join again. Okay, guys, just hold on for some seconds. I will be joining again.
Who is the worst scenario, it can be 3, and the person who is absolutely healthy without any issues, it can be 15. 15 comes plus 4 plus 5 plus 6, that comes 15.
Hello, sir.
And
Hello.
yes,
Sir, your PPT is not visible, sir, and your
yes,
video is getting paused. Sir, kindly rejoin, sir. PPT is not visible, sir.
okay, okay. I'm trying to rejoin. Is it visible?
Yes, sir. Now it is visible, sir.
Is it visible?
Yes, sir. Yes,
Yes,
sir.
no.
It is visible now, sir.
Shantan. Okay. Sorry for the interruption. There's some technical glitch that has happened.
Yes, sir. Just
You know, we mean for eye verbal things, and we see the motor functions. What are the values? What is the value of I is 4. For the verbal, it's 5. Motor thing is 6. So the lowest score can be 3, and the highest score can be 15. So prognosis. Now we go by what does this 4 thing E4, what does it mean? In stimulus, eye opening to speech, and eye opening is spontaneously the patient is opening his or her eye. So I'll demonstrate a situation in which we have a E4 situation, and you go to a person and you see his eyes open, then you think it's the patient is E4. But it doesn't mean the patient is sleeping and you record, you tell the person that he has an E3. No, because when you go and wake him or her up, she's going to open her eyes, and then you say, oh, the patient is E3. No, it should not be. If the patient is sleeping, then you should consider the patient might be sleeping. Then as you are talking, the patient is keeps his or her eyes open. You can assess that it's E4. Now a scenario of E3. We go to in front of a patient, eye opening to speech, which means E3 means eye opening to speech. You go to him and you tell him, you open his eyes. If you talk to that person, the person opens his eyes. And you say hello, and the patient opens his eyes. Then only the patient opens. Until unless you say something, the patient doesn't open his or her eyes. So at that time we have E3. Closes eyes. The moment you say hello, opens eyes. It's gone when you don't say hello, his eyes closed. That is the E3 scenario. You're going to record the patient as E3. Now this is the scenario for E2. In these patients will only they open their eyes in response to a stimulus, pain stimulus. But do not go for a trapezial squeeze. Right now, I've seen many people, even many clinicians I've seen, they go and straight away go to the patient and start pinching their trapezius, the neck muscles, or pinching certain areas that are very that can be painful way is to pinch on the lunar area of the fingernail. Lunar area of the fingernail and the central stimulus such as the stability should be avoided. You can also supraorbital press also you can give. little bit of pain, supraorbital pain. That can also be given to find whether. If now if you now you give a pain, you pinch. Now the patient opens his eyes. You give a score of 2. And what do you mean when I say E1? E1 I have written because if it is E1, the patient will not open his eyes even to pain, even to verbal stimulus. So that is the case of E1 scenario. Now we go for a verbal response. First, if the patient is having the best response, that is oriented, well-oriented patient can respond smoothly, is oriented 5. If it is 4, then he will be saying things in a confused manner. And if it is 3, if you will articulated speech, but there will be no conversational exchange. And number 2 is incomprehensible sound, and number 1 is verbal response. No verbal response will be there. So I have come from down to up. There is highest value to the lowest value. The highest value is the person patient being a good verbal response. So by what do we mean by this? You can ask the patient's name, age, where are they, why they have come, what happened to them. They will be able to say exactly what has happened to them, where they are. They are quite jolly well doing. Now another category is the confused patients. The patient responds to questions coherently, but in some disorientation. What I mean to say is, suppose you ask the patient that what date is today. The patient will always answer for a date. Maybe he or she, or the day of the week, if you ask the patient, maybe he or she might be a little confused, or he or she might be a little non-responsive, but still the person will be able to respond something about the day of the week. If you are asking the question, maybe he or she will say somewhat Saturday. If it is Monday and you ask the patient what it is, he might be saying that it is Saturday. But he will answer question in relevance, coherence to what you are asking. Maybe that will not be correct what he is asking. Now another is what is inappropriate words. That means you ask the patient what day of the month or of the week is it. Then he might be answering that my father's name was this. I would love to eat something very different from what you are asking. That actually will not mean whatever you are asking. So it's the B3. And if it is incomprehensible sound, for example, you go and talk to the person, that the person will not be talking at all. Just muffling, may have some moaning sounds, groaning sounds, or wheezing sound. That's all the patient will respond and nothing else. And obviously for V1 means no response, the worst response.
Hello, sir. Hello.
Similarly, for the motor responses, we have yes.
Yes, sir. So actually, sir, many students are telling that they cannot just understand the voice actually, sir. So if you just can exit the meeting and join again, I said then it will be sorted out.
Fine, I'll try to do that.
Okay, sir.
Just want to ask you, till then I would request Dr. Mukesh Chhetri to talk something about the metabolic issues that are related to trauma. In the meantime, I'll get my things okay.
Okay, sir. Fine, sir.
So can the camera be shifted to Dr. Mukesh Chhetri for metabolic responses to trauma? After that, we become how the assessment is made.
Sir, you just do one thing, sir. You just exit from the meeting. Okay, sir. Just
clinical assessment is made.
Yes, sir. Then again join with the same link.
Fine, I'll do it.
Okay, sir. Yes, sir. You're visible, sir.
Hello.
Yes, sir. You're visible.
Am I audible?
Yes, sir. You're audible, but sir, it's turned it needs to be turned forward, sir. It should be rotated. Yes, sir. The board has become vertical.
Hello. just a second. Okay, am I audible?
Yes, sir, you're audible, sir, but the board is not visible properly, sir. And it's a flip.
Okay, fine. Okay, I'll talk about metabolic response to trauma. Okay, this is basically we'll try to build up a concept of metabolic response to trauma. So, what happens when there is trauma and what are the various responses that body tries to do? So first, let's try to understand. Let's build up this concept. Very very important. First, what happens when there is an injury? What do we understand by trauma? So I'll basically talk about individual terms. What is trauma? What trauma we basically have? And okay, am I audible to you?
Yes, sir, you're audible, sir, but the
Give a thumbs up if I'm audible to you.
because sir, the board is not like it's not straight, sir. It has just vertically.
Board is not visible, right? Audible. The board is not visible.
Yes, sir. Now it's okay. Yes, sir. Now it's okay.
Okay. So, what is trauma basically? Trauma or injury, they both are synonymous. Even surgery is sort of insult or surgery is also a sort of trauma. Okay. So when there is a trauma, basically when there is an injury happening to your body. So what happens basically, as we all know, what happens? For example, there is a trauma on the face or on your leg, hands, anywhere for a trauma. First thing that happens is we all know this. The second one, if you can understand what I'm writing, or if you can understand what I'm speaking, okay?
Sir, actually, sir, there is a reflection from the board.
This
That's why it's not visible. So I think some light is falling on the board. That's why it's reflecting. It's not visible.
Is it okay right now?
Yes, sir. Now, okay, sir. Fine.
Okay, I'll give talk on this. I don't want to take your time, but let's try to understand what happens, what response happens. Basically, this response we're talking about is also known as stress response. It's a term which was coined by a scientist known by Bergson. So, in response to stress, how does your body basically response? We're going to talk about that. So when there is an injury, we have hemorrhage. Okay, what can we have? We can also have tissue trauma. We also have, we can have some foreign body, like we can have cardiac debris. And very much we will have is the bacterial contamination. So these are basically the things you see a patient in the ER. When you go to ER, you can see a patient having blood loss, you can see a patient having maceration, various types of tissue trauma. You can see patients with foreign bodies. And
Sir,
they have
so it's a
the patient reports relate. We can also see the condition.
sir, they are telling that sir, nothing is visible properly and nothing can be heard. They can.
Am I audible?
Yes, sir, but the voice is cracking very much, sir.
Nothing is visible.
And sir, nothing is at all visible, sir. They are telling me. Nothing is at all visible.
Because either
The color of the pen.
okay, I'll change the color. I'll just highlight with the color of the pen. Okay, we are doing a demo. Okay, just tell me whether it is visible or not. Whether it is visible.
No, sir. Actually, sir,
Yes or
so
no?
light is reflecting from the board. That's why, sir, the colors are actually appearing hazy.
Now. Okay, you just try to hear. If the audio is clear, just let me know. We have a
Yes,
little technical glitch with this board actually. Okay, fine. Let's proceed. So these are the things we will find in a patient if we ask. Okay. Now, what are the things we're supposed to know basically of the response? So the next thing that we're supposed to know is we're supposed to know two things. That is, there are two sorts of uh, responses, or you can say two based on location. One is the local site, basically is where you have the injury, and next is distance, which we will be talking in detail. Okay, local is again comes to hemorrhage. Okay, there will be edema. We all know there will be edema. Okay, and third thing, sometimes we can also have water retention. Why am I talking about all these things? Because the next thing that I'm telling you is about the phases of responses of metabolic response to trauma. We have basically two phases which I'll be talking about. Okay, now let's focus on the other one, that is resistant. In resistant, what happens is basically, okay, one very important thing. Can you guys understand? Okay. In distant we talk about, first thing is peripheral vasoconstriction. Why do we have peripheral vasoconstriction? Peripheral as well as splanchnic. Because when we have hemorrhage, as I already told, we also look for blood. We need reddish. We need, hello.
Sir, the voice, sir,
Sequelae of
sir, totally the voice is cracking, sir.
sequelae of hemorrhage. Hello. So there is sequelae of hemorrhage. Am I audible?
No, sir, the voices are totally cracking, sir. It's not complete.
Since we're running out of time, let me proceed with the. I'll be joining again.
Okay, sir. Okay.
Hello. Yeah.
Yes.
I just put a call again with Dr. Chhetri. Here, you might be having certain technical glitches. Hopefully, for this time, my turn works out well. Is my screen visible now, Sayantan?
Yes, sir, it's visible now.
Okay. So, what we are discussing, the motor response, we have done E, we have done V, we have done the motor response. Now, what are the 6 grades of motor response? The first thing is M6. It obeys commands, but there is a high score. Second, the patient will localize the pain. Wherever you pinch the patient will make purposeful movement. That much is there if you localize. But avoid giving, a trapezius squeeze. But try with the supraorbital pressure. Supraorbital pressure gives a better indication, because whenever you give a pinch or a punch in the supraorbital region, what happens? The patient tries to move his or her hand, but if the patient can move the hand beyond the level of the chin, when supra pressure is applied, that means the patient is having a M5, can localize the pain. And the fourth point, next point we are coming is that the M4 value. Now the patient will withdraw from pain. That is, it will the patient, for example, if you give a supraorbital squeeze with your fingers, what happens? The patient will try to bring his or her hand to some extent, but will never cross the level of the chin. The patient will never be able to raise his or her hand above the chin. It doesn't mean this is not considered for the people who have broken their hands. That's not for them. It's to try to understand. It's we are what we are assessing is the neurological response, and or you can give a pinch on the hand. The withdrawal from pain will be more. You can get more better understanding from the pinch on the lunar area of the fingers. The patient will try to move the hands. That much movement will be present in patient with people with M4. Next we have the M3, which is the decorticate posturing. And this posturing happens, whenever you give pain, when a pain is accentuated, when you give pain to the patient, there is a flexor response in the decorticate position. In this this is the decorticate position. Most of you must be knowing, but for those who don't know, I will explain. There is an internal rotation of the shoulders. Can you see? The shoulders will be forward and rotated internally. The flexion of the forearm, the wrist with clenched fist will be there. Leg extension will be there, and there will be flexion of the foot, as you can see, flexion of the foot. Now the next posturing, this is also activated by pain, which is the extensor response. It's a decerebrated posturing in which this is the kind of posturing the patient will have. It's called adduction of the arm. Adduction is to add means to bring it towards the body. The arm will be brought inside towards the body. Internal rotation of the shoulder. The internal shoulders will be internally rotated. Over here you can see the shoulder. Pronation of the forearm and extension of the elbow will take place. The flexion of the wrist and fingers, you can see this wrist is flexed and the fingers are clenched, and the plantar flexion of the foot will also be present. This is due to the extensor movement. The other one is the flexor movement in case of M3. And for this M2 we have the decerebrated posturing. So this is the difference that we can see for those people who don't know. This is for them. So so how do you discriminate between a decerebrate and a decorticate posture? See, this is the factor E. When you say decerebrate, E for extensor response. So by that thing, always remember it is the E that is present that will give you the clue. It is the cerebrate posture. Extensor posture means the cerebrate posture. Now M1, there is no motor response. So all these three components, eye, verbal, motor response, whatever we saw, is the function of the cerebral cortex and upper brain stem. It does not give any indication about the brain stem. So don't think Glasgow Coma scale gives every information about the brain. You only get to know the cerebral cortex and the upper brain stem. That part is only assessed. We don't get something from the brain stem. As I said, the MCQ will be asked based on whatever we are teaching. In case you have during the technical glitch, don't worry. I'll give you the PPT link, and you all will those who will be interested can have the presentation of my PPTs within you, so that you're able to answer the questions. Now, similarly, there is another scoring system. Like right now, we came to know Glasgow Coma scale. This is AVPU. This is also very important, and this is very simple. It is not that much complex as Glasgow Coma scale, but all you have to do, you first ask the patient. We see the patient is alert. If it is alert, write A. If the patient responds to a verbal stimulus, write only, then write V. And even after verbal stimulus doesn't work, then you give a painful stimulus, you write P. The patient responds to pain. And the patient is totally unresponsive, give the score of U. I repeat, A, V, P, U is very easy. Alert, then verbal stimuli, then painful stimuli, then fourth one is unresponsive is you.
That's
So based on this, it's very easy thing to do, and it's a very rapid way to score a person when you have little time with you. So how do we compare ABPU with GCS? For example, a person who is alert, you can consider the person to be around 15. If the person is responding to a verbal stimuli around 13, if the patient is responds to painful stimuli, it is only 8 around with a little grave, and response unresponsives can be 6 also. So this is in relation to the GCS, the ABPU score. You have to mind it. Those people who are into GCS and suddenly you see a particular note, a worksheet in which anyone has mentioned something ABPU score, so you have to consider these things for your understanding. Similarly, an ACBU score, which actually I never used, but still for your reference, it is sensitively alert, confused, drowsy, and unresponsive. We see the GCS being written 15, 13, 10, and 6. So this is how you're going to note for ACBU, but I have never used this scoring. Another thing very important now, you have to understand what is the sequence of assessment. As I said, A for airway. What do you mean by that? It doesn't only mean that you have to only look after the airway, you have to also look after the cervical spine. This is very, very important. People think it's airway means only the airway that we are looking for. No, also you should stabilize cervical spine, because most of the trauma patients, RTA, MVI patients, or any assault patient, there are high chances they have a cervical spine injury. So first is important. That's very important that establish cervical spine control. This is very, very important. If then immediately first thing is stabilize the cervical spine, then ask, are you all right? क्या आप ठीक है? अपनी भालो आছেন? If there is a coherent response, then the patient is fine. And if there is a coherent response, then what is the inference that you will get? That why do you say the patient is fine? Because it signifies that the airway is present at that point, is okay, and the patients satisfy criteria B, C, and D. As I said, B, C, and D, as I said, there is B for breathing, circulation, and assessment, the detailed assessment that we will do, which is see that later on. So it means the patient is doing fine, and when the patient is giving a response, it definitely you think that airway is present. If the patient wouldn't have responded, the patient airway wouldn't have been present. And if BCD, that means the breathing and circulation wouldn't have been okay, then only the patient will respond well. So that clarifies that. So that is the way how you're going to justify yourself that yes, the patient is okay. So a coherent response is always a good response. And this is how you're going to explain it within yourself. For the patient to respond verbally, there must be an adequate airway. So this is what I want to explain. If the patient is given a good response, that means the airway is okay. And there should be sufficient breathing and ventilation to allow for celebration. That means there is the oxygen is reaching the patient's brain. That means the neurological status is also okay. But remember, consciousness will be lost only if 50% of the circulating volume has been hemorrhaged. This is very important. When will the patient will lose consciousness? The 50% of the circulating volume. But remember, a patient who is talking well, coherent, might be a candidate in which at least say about 25% blood loss had occurred, but still the patient is doing well. So always be wary that there are chances that he might be having bleeding that has to be assessed in the secondary form. But initially, primary inspection, you will think patient is okay, fine, stabilized. Now you have to cool down, then look for bleeding or circulating issues. So it means the patient who responds verbally to direct questioning has greater than half the circulating volume. But the patient not responding, that means the patient has lost 50% of the circulating volume of blood. So coherent verbal response will also exclude a significant head injury at this stage. Because obviously significant head injury, because the motor, the neural function is okay and the patient is able to respond. So the verbal, so if I go for E4, V5, M6, at least we can say the verbal response is V4. So the patient is doing well. Now, remember, unobstructed airway is the main goal of the main airway management. That means you have to produce, you have always have to look for things in which you have to think that the airway should be unobstructed. You cannot keep anything down the line in the airway so that the patient is unable to take breathe in oxygen. Why it's important? Because it maintains, because if airway is okay, then maintain cerebral oxygenation will be proper and to hypercarbia will be minimized. Otherwise, if hypercarbia precipitates due to carbon dioxide, there will be permanent cerebral impairment. So you cannot let carbon dioxide to collect inside the trachea or inside the lungs. So if suppose if patient's trachea is blocked somehow and there's hypercarbia, the blocking has happened like a valve system, so one-way valve. Suppose the patient can breathe in, but cannot push out air like a one-way valve. Then what happens? There will be the collection of carbon dioxide. There will be hypercarbia, and this carbon dioxide is very deleterious for our brain. You have to learn to be very suspicious. When you're seeing a patient, you always be suspicious, because if you take an intervention at the right time, the earliest time, the chances of the patient's survival, there's chances that the less chances of some kind of fatality or morbidity, serious morbidity. But this is the reason why I've written this line. I'm going to read it out. Remember that an apparently agitated and aggressive patient may actually be acting inappropriately because of hypoxia and not assumed to be intoxication. I have mentioned this very importantly because most of the time, for sometimes you might come across patients with trauma who are already intoxicated, and you can find them agitated and shouting, but do not just ignore it. Please do not ignore it, because this agitation could also be due to hypoxia and not due to his alcohol intoxication or whatever drugs he is into. So always be suspicious. Try to rule out these causes. Now, for example, now how are you going to balance the patient? For example, the patient, first of all, open the patient's mouth, inspect with your eyes, see through inside his or her eyes. See whether there is any kind of denture. People wear dentures. So any kind of dentures sitting inside, or if the person has having any kind of food. So try to look for that evidences. And if you find something, use your two fingers to glide inside the mouth and make a sweeping movement to take it out. Do not be careful that when using your fingers to take it out, that you don't push that thing more inside. And every emergency care personnel should be aware of a chin lift and a jaw thrust maneuver who are dealing with trauma. That's very mandatory. And so what you have to do, the chin lift, you lift the chin up and thrust the jaw up to make the airway straight. You actually make the airway straight by these maneuvers. There are other techniques such as oral and nasopharyngeal airway insertion is there, which actually I'm not going to go because this is a part of an advanced life support maneuver. But okay, LMA masks are there, LMA things are there. You can also apply LMA to deliver oxygen. So there are many kind of oxygenation things, but I'll show you later on. So this is exactly the sequence that you're going to see. If the patient does not report, tell the patient to open the mouth. Now you make a chin lift and the head tilt the head. This maneuver is very important. With the non-dominant hand, you keep it on the patient's forehead, and with the dominant hand, you lift the chin up so that you can see that the airway is a straight line, so that air can enter the lungs in a straight manner. And this maneuver is also important at jaw thrust. You can see the you just pull up the jaw upward in a rotatory anterior rotation manner, so that you relieve the airway at the posterior part of the pharynx, so that it becomes a straight line. It becomes the cavity actually extends well, distends well, and so that there is a lot of air for to pass through it. Remember, any secretions you have to be it has to be removed with the suction or with the rigid sucker. This is very important. So that's what I was telling you. I'll show you the oropharyngeal tubes. These pharyngeal tubes are very handy and must be used. And how to take a measurement of the tube? This is you see the level of the lip to the angle of the mandible. The length you is because these comes in various sizes. So based on which size to use, how this is the way how you are going to measure the tube length. Now, what do you think? You're going to directly plunge in this particular tube in the patient's mouth like this? No, actually you're going to do in a reverse order. That you see the curvature. You should push this particular oropharyngeal tube in a reverse order, then turn it, and then you are going to place it in the posterior part of the pharynx. This is the way. First, you enter it in the reverse order, then turn it. Do not try to move the thing directly straight away in this way. If you can injure the patient, so the right technique is very important. These are nasopharyngeal tubes, and with this, the tip of the nose or the nares is very important. This nares from the tip to the pinna. So this is the size that you see. After that, you can put it through the nose. So after you manage, so this is another way of management. Now you want you need a more aggressive way to control the airway. So that is more important thing is the cricothyroidotomy. We are quite well aware of the cricothyroid membrane, and this is the cricothyroid. This is the thyroid, but we are seeing. The goal is to make a hole through the cricothyroid membrane and enter the trachea as early as possible. And this should be what I am going to demonstrate is not cricothyroidectomy, but only I'll mention about needle cricothyroidectomy, because we are talking in an emergency scenario. We're not talking surgical cricothyroidectomy or any kind of surgical procedures that we need to do in that situation. We are only trying to say that we'll do whatever we're going to do, we have to act very prompt and fast. So this is with needle, I'm going to pierce through somewhere this region and I'm going to deliver oxygen. That is the goal. So you palpate it. This is the prominence of the Adam's apple. Then you can palpate the cricoid cartilage here, and it is in between this region, this zone. You will be putting your needle. A 14 gauge needle is enough. For example, if you're in a higher center, that's fine. But if you're in primary centers, even use a 14 gauge needle to puncture that area so that you're able to connect it to an oxygen line later. Somewhat like this, you're going to puncture it and it's going to reach straight away stab. It's like stabbing open the trachea. So for a proper cricothyroidectomy, this is the whole set that we are having. There's a guide wire which is very important. There's a syringe which is used, and there's a knife blade which is used to cut it off, and this is the dilator catheter. I'll show you a demonstration video how to do it.
Palpate the cricothyroid membrane with the non-dominant hand while mobilizing the larynx with the thumb and the middle finger.
This is
Attach
the operator just
to a syringe
using the syringe. It's the syringe packed with saline.
Insert the needle at a 30-degree bottom angle while applying negative pressure on the syringe.
Make sure caudal angle is very important. You have to give it from the chin side, the caudal side. Now you push the syringe in. You can see the air coming up.
Thread the guide wire.
Then you have to pass the guide wire. Now after you pass the guide wire, hold the needle or take it out. Guide wire should not be dislocated. Be careful about that.
Make a 1 to 2 centimeter incision.
A small incision, a cut is made at the level of puncture.
Membrane at the entry point of the guide wire.
Now you need to secure the tube also. Now you have to secure the airway also. In this case, ambu bag is given. In case of hospital, you have to give oxygen. Now you secure it with the tape. So this is what we saw. We saw a guide wire. There's a blade. There's a dilator. There's a sheet. There's an introducer needle, and there's a. And why this was used? This was used to check whether the needle has entered the trachea, because with this particular syringe, if you have normal saline, you're going to see air bubbles coming in. Now, what is the disadvantage of needle cricothyroidotomy? Can anybody of you answer me this question?
Okay, guys, can anyone of you answer the question? Given that, what is the disadvantage of needle cricothyroidotomy? So, if you know the answer, kindly write it in the comment section. So, the stenosis of larynx, patient can't speak.
Okay. One.
Anyone else?
That means
Damage of the larynx.
it is no. The thing answer right answer will be the window period is only 40 to 45 minutes. That means you don't do a cricothyroidotomy to making a permanent procedure like a tracheostomy for a longer duration procedure. It will only be effective with the needle cricothyroidotomy. You are going to give only 40 to 45 minutes support. You actually what you are doing actually buying time for the emergency team, for the expert team to arrive, those who are going to take care of the patient. Because after 45 minutes, hypercarbia will develop and carbon dioxide will develop, and that will carbon dioxide is obviously very deleterious for the neural system, the brain and the cerebral system. There is cerebral vasodilation, and with the cerebral vasodilation, the blood flow will increase and elevate and already in raising in ICP. And so there is already an intracranial hemorrhage after trauma, and what will happen? You will go into the more cerebral blood flow. As a result, more intracranial pressure will increase. Happen occur. Now, another question: what is the gold standard of estimating that satisfactory intubation of airway? How do you measure that? That you say that the satisfactory intubation has been made.
Guys, the next question: why is the gold standard of estimating that satisfactory intubation of the airway has been achieved?
How do you get to know? Anyone? Nobody? I'm waiting for Sayantan to speak up, but no one.
Yes, the answers are coming up. The oximeter, chest movements, when
Mhm.
there is no sign of pneumothorax activity.
Mhm. No, remember, it is the carbon dioxide. It is the PCO2. It is the that is capnography, which is very important. That is PT, endotracheal CO2 concentration. That has to be test. That is very very important. So I'll just summarize the airway part. Airway is not only about only just doing with the airway, making it straight, taking care of the airway. It's also about the spine. Stabilize the cervical spine using a collar. Then do every steps to keep clear the airway. After you clear the airway, then you also have to think about making the airway run in a straight line so that oxygen and air can pass through the whole airway tree in a very proper order, the best possible way. So for that we have the chin lift and jaw thrust maneuver, which I told you. Then we also learn some non-interventional airway methods like oropharyngeal, nasopharyngeal tubes, and lastly we saw that we had a cricothyroid needle, uh, the cricothyroidectomy, which is very important and which is essential. If some kind of intervention is needed, then only we go for it. So, but it has to be done with a needle because we are actually buying time, which actually for that we get a window period of 40 to 45 minutes. Otherwise, hypercarbia will develop. This is a recovery position, what we all are seeing. But do not do keep the patient in a recovery position if the patient is having a spinal cord injury. Remember it. There is a tendency of some people to keep patients with a spinal cord injury or a cervical spine injury in this position. By doing this, by making these kind of movements, you are going to jeopardize the life of the patient. Now we come to the breathing part. Now we have seen the apparatus that is responsible for the air to enter. We have taken care of that. Now we have to see the machinery that is actually pumping the air into our body. That has to be now taken care of. So that was the priority. Now the priority. This is the priority. Now this priority comes only after an adequate airway has been ensured. Then now you're going to check the efficiency of the ventilation. But how? Question is how? How are going to check efficiency whether the ventilatory mechanism is working well? Yes, auscultate the chest in even the axillary area, so that you are also able to understand whether the peripheral the oxygenation is taking place or not. That is also very important. You should also record the respiratory rate, whether patient is in apnea, hyperpnea. So all these things you have to note. Because serious chest injuries will definitely give these kind of things: pneumothorax, passive pneumothorax, open sucking pneumothorax, cardiac tamponade, ruptured diaphragmatic rupture also takes place. So this has to be looked for. So this session is not for about being for seeing all these kind of cases or determining these cases. The idea of this particular session is to understand that the patient has some kind of chest problem and what are the responses we are supposed to do, and then hand over the case to the respective specialities. So a diagnosis is very important. So how are you going to because you make a diagnosis through certain clinical findings like deviated trachea, the absence of breath sound is absent, the dullness and percussion. You should percuss over both the lung bases. That is very important. And also you can find muffled heart sounds. Becomes very muffled. So these are the four things that should be kept in mind while we come to a diagnosis of a chest injury. It can be all the fours, it can be a combination of any one. So radiologic findings, radiographic findings are very important. Loss of lung markings, so the lung markings will lost, there will be deviated trachea, raised hemidiaphragm, and fluid levels will be found inside the lungs. These are the so if someone is who is not aware of the chest X-ray, one should go about with the chest X-ray. Probably we'll have something on a chest X-ray some other day. So the biggest intervention is to put a chest drain. That's very important. The best intervention. Most of the cases, we need a chest drain. It is that so how is a chest drain is placed? It's placed in the interthoracic region through this fifth and sixth vertebrae, or fourth and fifth vertebrates. It's passed that a tube, a drain is passed through it, and a chest drain is placed so that all this pneumothorax is taken care of. But in case of cardiac tamponade, you have to use the spinal needle. I'm not going through the total process of chest drain, the process because there is a total step-by-step procedure. But our cardiac tamponade will definitely play. But what happens in cardiac tamponade? There is a huge collection of air, of fluid, or blood in the pericardial area, pericardial region. As a result, there is a diminished movement of the heart, and you can use it using wandering lead of with ECG. You place that thing and connect the needle tip, and you put, and it helps to explore the cardiac area, the pericardial area. And what is the idea behind the needle tip? Because as soon as the needle tip goes inside the body, it can actually detect the heart movements and pulses, so you are able to do it in a better way. But nowadays, it was a very old technique. Why I mentioned it out here is that because if you are in the primary center, you will be able to manage the patients where you don't have the echocardiography facility there, or a USG facility there. It's not available. Then only you can have to go by this needle technique of managing cardiac tamponade. Again, a very important thing: oxygen supplementation is needed. So that's I have summarized very briefly in what we are going to do, and what we are going to do much in the breathing thing. Is most of the things is related to the assessment. And if you find tension pneumothorax, that is diaphragmatic rupture, any clinical signs relating to that, that means you are going to conclude that the patient has a chest injury and might be needing a chest drain, or if the patient is having cardiac tamponade, and the management of cardiac tamponade will be very important. So that is the only thing that you conclude, and your rest you are going to send the patient, because this is not part of the primary thing that you're going to do. You are just going to stabilize the patient in this scenario. Then the secondary, or the main final targeted goal will be done by the specific surgeon. Well, this is very important. Circulation and hemorrhage control. This is very important, because without circulation, because these people, most of the trauma patients, we know there is huge loss of blood. So use a white bore needle, and you have to try to give fluid as fast as possible. It's very important that we transfer fluid very fast. I'm going a little fast because we are running out of time. But there are certain equations that you have to remember. The circulating volume of the adult is 7% of the total body weight. So remember this: an approximately 5 liter in a 70 kg patient, that is the 7% of the body weight, is actually the circulating volume. So why body weight is important? By measuring the body weight of the patient, you have to assume something. And in case of a child is 80 to 90 ml per kg body weight. These figures are very important, and you should keep this in mind. But obviously after a trauma, the patient is hypertensive. Always have this particular thing in mind, that it's definitely due to hypovolemia. At the first instance, think that way. So now the result, whenever there is whenever there is shock, there's hemorrhage. The main goal, then objective, is to resuscitate the patient with fluids. The fluids, as we know, it can be crystalloid, colloid, or blood, whatever you find you have to give. So right now the patient is in an emergency situation, and so if the patient does need the fluid, then you have to give whatever you are getting in front of you. Means I mean crystalloid, colloids, or blood. So if you are giving crystalloid, then use 3 ml of crystalloid to 1 ml of blood. That means if 1 ml for every ml of blood loss, you have to replace with 3 ml of crystalloid. This is very important. It's right now the recommendation of using colloids has come down. We are using crystalloids more because we have come now syringe pumps. There's hemorrhage. The main infusion pumps are there. So all these infusion pumps, help give the delivering fluid in a very fast rate. So what should the initial bolus? Give an initial bolus of around 2 liters, and as quickly as possible, maybe within 20 to half an hour. But in case of children, this figure is very important. 20 ml per kg in child. These figures are very important. Keep this in mind. This will be very important to your whole life. Now, after you give fluid, you have to assess the patient's how the patient is responding to your fluid resuscitation. If you see that patient is doing fine, fine. But if the patient is not doing fine, if you can recognize that there is a surgical shock which is precipitated by seeing a cold, clammy hand or obtunded consciousness, or you cannot palpate the peripheral pulses, then you have to start an aggressive fluid resuscitation and blood transfusion. Arrange for blood transfusion. For example, if you're seeing a patient is dying and you're not getting blood, even a blood O negative blood can be given, without any issues, because it's a dire situation. But it is totally optional based on your local protocol. That means whatever region you stay and how you are secured medically. So whenever there is hypovolemia, then what happens? Tachycardia happens. These are common things of physiology, but still giving a refresher. Obviously, hypovolemia related to tachycardia, hypertension, narrowing the pulse pressure, systolic versus minus the diastolic. There is a tachypnea, delayed capillary return, falling of urinary upload. These are the things that are going to happen. Everybody knows. You all have studies. I mean to say. So idea is about urine output is very important. That's a very important thing. These are special notes you have to keep in mind. Care must be exercised when treating fit athletes. For athletic people, they can sustain a significant volume loss. So, if you know the history from a person's history that he's an athlete, so always be suspicious. Probably he's okay. He's pretending to be okay, but they can sustain blood loss because their physiology is quite stronger. Their whole system is stronger than us, than a general population, and so you should be careful about it. And older adults, why older adults? You also be very careful because they may demonstrate normal physiological responses to volume loss because they are on beta adrenal receptor blocking drug, the beta receptor, the drugs. Then we see. I hope we know what is tachycardia. Tachycardia will be generalized based on the age. This is very important. 100 beats a minute in an adult, 120 beats. This is gone. Can you hear me? My board is missing.
Yes, sir.
Just hold on.
Yes, sir. Yes.
I pull it up. Now you all are very quiet. I hope you are able to appreciate what is tachycardia. That's 100 beats per minute. Tachycardia is defined as a condition in which it depends on the age also. The chronology is also very important. For young. So you must know this range. Some people tend to forget. These are the things you should remember. I'm not going. Just keep in mind. Just to give you a recap. So urine output is very, very important indicator of what the cardiac output. So you have to, so in order to see the cardiac output, you need to place a urinary catheter, which is very mandatory. It mandates that. In male patient, catheterization is contraindicated presence of urethral tear or suggested any scrotal hematoma, blood at the or the penile mere test, or if you find an impalpable palpable prostate or a high riding prostate in the males, then it's contraindicated because because the chances of injury by putting a catheter you are to enhance the injury. But in case of females, urethral tears are exceptionally rare, and so this is not an issue. But catheter can be given to females. When urethral catheterization is contraindicated, then what are you going to do? You are going to give suprapubic catheterization. That's very important. Now, after you catheterize, what you are going to do? You have to check the urine output, which is minimum of 50 ml of urine per hour in case of adults. Then you're going to find, or for a child is 1 ml per kg body weight per hour. For children less than 1 year, 2 ml per kg body weight per hour. That is the order you have to follow. Keep these figures in mind. This is very important. Therefore, monitoring catheterized patient, you need to find the urine output, because by this urine output, as I said earlier, cardiac output is very, very demonstrated, very, very much demonstrated. So that is actually signaling thing that's what is the exactly what cardiac function, the cardiac output of the patient. So now there are chances of aspiration of food, alcohol, or whatever the person has swallowed. And sometimes the people swallow blood most of the times. So you have to decompress the stomach with a wide bone nasogastric tube, and you put it inside the stomach. Now, can you see this X-ray? Can you tell me what is this X-ray? Anyone who is sure can unmute and answer the question.
Okay, guys. Like, if anyone want to answer, please turn on your mic and just answer us.
Nobody?
Okay, sir. Okay, so it's a request from one of the students, sir, to kindly hide the sharing option box. So, like, there is option C, so you can see in the screen is a hide option. Kindly to click.
Oh, or hide. Okay.
Okay, anyone want to answer? You can see the radiograph on the screen.
Listen, this yes, come on.
Sir, here we can see the airway tube and sir, the EEG recording
lead,
sir.
Fine. That was a good try, but that's not the answer. What we are saying, someone passed a nasogastric tube through the nose and it reaches the brain. Remember, in maxillofacial trauma, it is very, very important to know that always be careful of skull-based fractures. When you have skull-based fractures and you try to put a nasogastric tube, be very careful. You must know the anatomy, you must know where the tube is going. You must be sure about it. Otherwise, you're going to land up in this scenario, pushing a full-blown nasogastric tube into the brain, which can be very disastrous. So be careful. So maybe you have put a nasogastric tube for decompressing the stomach, or nasopharyngeal tube for giving oxygenation. Even a nasopharyngeal tube can go inside the brain if not put properly. If there is a midfacial trauma or especially the skull-based fractures. So be careful. Now we are going to disability and neurologic evaluation. I'm going a little fast. We come from this. Whenever there is a craniofacial trauma, there is associated head injury. So what is a head injury? Trauma to the head injury? That is scalp. It can be on the scalp, skull, or brain, or any combination of this. So there is definitely a loss of consciousness, even if no matter what, how brief it can be, but there is a loss of consciousness. It can be open or closed injury. So in case of all open lacerations, I mean, even if it is a small one, do not ignore. Please do not ignore. Always explore it with your fingers, you know, and because there can be an underlying, you know, well, the opening of the skull. You know, there is kind of fracture which is quite open, deep, gone deep inside, and the brain is exposed. So you have to, in that case, you have to send involve the neurosurgeon in that case. So you should inspect it quite properly. But open are not very common, but closed injuries are very common. In the closed injury, there is a kind, there's a mild kind of concussion takes place with mild changes in intracranial and arterial blood pressure also happens. But however, this is quite manageable, and the patient has shows the least residual deficit. So these are good candidates. But the problem is when it happens, when severe injury happens. In a case of severe injury, what happens? The sequence happens is that there is a change in the intracranial pressure. So I mean to say, in case of brain, we are not talking about abdomen or legs or anything else. We're talking about the brain. Since we're talking about head injury or the maxillofacial injuries, we are not talking about especially that happens in the brain. In more cases, it's the intracranial pressure that it changes in the intracranial. Maybe there a decrease, then there is a rise in the intracranial pressure that happens. I'll tell you later on. The arterial blood and pressure and temperature, all things that go haywire. The biggest problem is diffused axonal injury, in which the brain stem and everything moves, and all things are just in a very tearing motion. That is, the nerves, they get torn apart, and obviously these cases have a poor outcome. Head injuries can be minor or severe depending on whatever the way it happens. Minor, even if it's minor or severe, depending on a degree, things happen. Physiological things takes place. But initially, there's increase in intracranial pressure, and these, due to the increase in intracranial pressure, the patient becomes unconscious. Then in the later stages, if the ICP rises, the associated edema of the brain tissue, because after there's an edema. Whenever there is injury to any tissue, there is edema. Due to this edema, the intracranial pressure increases. The classic extradural hematoma occurs rarely, and very small part of the patients in the class with the classical signs of extradural hematoma. Acute subdural hematoma more common, is as a more higher mortality rate than extradural bleed. Subdural hematoma is a space occupying lesion. Remember it, and it increases in rapid increase of intracranial pressure. Why the intracranial pressure? Rapid increase in intracranial pressure because edema. Because whatever the first thing, the inflammatory mechanism starts to play, and there is a rapid increase of ICP. Now, the thing has happened inside the brain, and now there is a compensatory mechanism of the brain, and which the brain will try to decrease this increased intracranial pressure. How the brain is going to do? It will try to decrease the CSF volume. It will try to decrease the arterial blood pressure. Due to the effect of the increased ICP in the intracranial thing on the baroreceptors which are present inside the blood vessels, they alleviate some of the mass effects. If you decrease the arterial pressure, naturally the mass effect, that is mass occupying, the space of occupying effect of this particular hematoma is a little bit decreased, but it doesn't stay for long. Now, when the compensatory mechanism they exhaust, then there is a rise in rapid rise in intracranial pressure occurs with rise in blood pressure, and the patient demonstrates the sign of brainstem compression. That means the patient has a brainstem compression. When the compensatory mechanism fails, at a point of time, this compensatory mechanism will fail, and at the time the brainstem lesion or the brainstem signs are quite evident, and you have to treat it very aggressively. And Otherwise, the patient will die very soon. And it's, as I've mentioned, 24 hours. When there's any damage to the brain substance, what happened? There's edema, there's increase in intracranial pressure, and it develops within 48 to 72 hours of trauma because the edema starts developing and gradually increasing and increasing, and find it takes 48 to 72 hours for the edema to happen. So, cerebral blood flow, the two factors actually will determine the cerebral blood flow patterns with the partial pressure of oxygen and PCO2 of blood, arterial blood. They actually give them. So anything that the arterial pressure, anytime the partial pressure of oxygen reaches less than 52 mmHg or 50 mmHg, that means there is an increased cerebral blood flow. And when there is an increase of PCO2 of 45 mmHg, then also it will cause an increase in the cerebral blood flow. This increased edema and therefore and rising intracranial pressure. That means whenever the cerebral blood flow is increased, there is more edema, more fluid will be lost inside the brain, and therefore more intracranial pressure will increase. This is just a small pathophysiology of the mechanism of neurotrauma. In short, now what do you understand from the impaired ability of the brain to autoregulate the cerebral blood flow? It happens, it is actually the cause is with hypoxia, it can be to the brain trauma, or it can be ischemia. So when this autoregulation, the brain loses, that impairs, it is these three factors, the three main gold factors, that is hypoxia, any kind of hypoxia, any kind of brain trauma, or any kind of ischemia will lead to the impaired ability to auto-regulate. The brain always tries to regulate, right? So what is our goal? The goal is to minimize the effect of the intracranial pressure. That is, we know that more intracranial pressure, the more deleterious it is for the brain. Now, three ways to compensate this, to fight with this effect. One is oxygenation, oxygenate the patient, resuscitate with good amount of fluids, and then you have to put the patient on elective ventilation to reduce the PCO2, because you have to blow off the carbon dioxide from the lungs, because the more the carbon dioxide retains inside the lungs, that is more PCO2 develops, and more PCO2 means more increase in the ICP. Okay, that's a short thing of the brain. Now we call the abdomen. This is the soft area of the body, and there's very much chances of occult blood might be there. So always be suspicious. Do not ignore abdomen, because 20% of the patients who have acute hemoperitoneuria, they don't even demonstrate any signs of the peritonism. So, but if you neglect it and if you do not see it, then it can be very fatal. So the bleeding because the bleeding within the peritoneal cavity, that is within the abdomen, can happen in the peritoneal cavity, peritoneal space, and a pelvic cavity. These are three big cavities in the abdomen that are very much vulnerable for the clot or bleeding to localize. The idea is that is not that you are going to do any kind of abdominal surgery at this stage. At this stage, what you have to do, since you are doing a primary survey, since you are primarily looking at the patient, so very important is that what has happened is not whether the clot is in the peritoneal cavity or the pelvic cavity or the retroperitoneal space. That is not important. The main important thing is that is there an injury? You have to find out. You have to ask yourself, is there an injury? Yes or no? You have to find out, because if there is an injury, because if the patient needs a laparotomy, if you are not a laparotomy surgeon, then you have to send it to the respective expertise. But accurate initial diagnosis is not the important part of the primary diagnosis, primary scenario. So how do you do it? The standard abdominal examination is very easy. Inspect it, palpate it, percuss it, auscultate it. Then after you do it, then you examine the rectum and the perineum. Why else go for a rectal examination? Because If there is a spinal injury, there will be absent or diminished sphincter tone. The anal sphincter tone will diminish because the spinal nerves that are supplying the sphincter will be affected, and so that will give an indication of the clinical sign of spinal injury. That's the reason you're going to check the dictum. You can actually palpate the pelvic fractures will be can be palpated easily. Then if you the palpate the lower abdomen, or you can find a high riding prostate, there are chances that of a urethral damage is there. You can infer from that. Urethral tears in female is rare, as I told you, but urethral damage is main is there. So there is scrotal hematoma, blood at the penile meatus is present. Suspend any kind of urethral catheterization in these kind of patients, because if you try to do it, you're going to injure the patient more. So immediately send the patient, if possible, send for the ascending urethrogram, in which you can see the total urethral pathway, whether it's clear or not, whether you can put a catheter. If not, if you think that you cannot put a catheter, you have to put a suprapubic catheter. Consider putting a suprapubic catheter in these patients. Another thing is the gastric decompression is very important. You have to nasogastric intubation is important, because you have to take out all the secreting blood which is inside. You have to clear out whatever there is, because otherwise there's chances of aspiration is there. Now, and there's another thing happens, that acute gastric dilatation can take place. So, but be careful that don't try to put nasogastric intubation in maxillofacial or mid-face fractures, because of that what I showed you in that radiograph. Always consider putting up a orogastric intubation tube, which is very important in this case, in mid-case fracture cases. Otherwise, if you're not very sure about the anatomy, if you're not very sure about putting a nasogastric tube, don't try it in patient with a mid-face fracture at least. And what will happen if the person aspirates or acute gastric dilatation takes place? It will actually impede venous return, and when there is impedance of venous return, perfusion will not be proper. Well, diagnostic peritoneal lavage is also done. It's 98% sensitive, but nowadays we have lots of USG, lots of mechanism to advanced imaging systems to find out. So, but I've just mentioned this diagnostic peritoneal lavage for those people who might need it, who might be probably your students. Maybe you someday will be working in a primary health center where you may not be getting advanced imaging systems. So in that case, diagnostic peritoneal lavage will give you a good inference. It's because it's 98% 70 positive for intraperitoneal bleed. So that's how you're going to diagnose. So what you're going to see? You're going to see frank blood comes when you aspirate. Frank blood is there. Then you can, if you see it for the laboratory, if you find that the WC counts will be greater than 500 cells, will be present, will be there in that fluid, gastric fluid. RBC count will be greater than 1 lakh. Bowel content will be there, bile, fecal materials or bacteria might be there. Urine might be there. So you have to look for all these findings. So if you find all these things, then you get to know that there is a injury within the abdomen. That's what I wanted to know. There is an injury within the abdomen. This is the important goal of the primary survey. We are not going to specifically treat the patient. We are only primarily stabilizing the patient. So this concept is all about that. So a positive DPL means we have to go for an emergency laparotomy. If a person has acute abdomen, if you palpate the person and find the patient has person has acute abdomen, no need of doing a DPL. Acute abdomen, no need of doing any further thing, because acute abdomen means the patient needs an immediate laparotomy. So there is no point in doing this case of acute abdomen. That's what I mentioned. Why should we not do in case of an acute abdomen? Because indications for emergency laparotomy already exist. So why should you go for that? So I'll not go much about the DPL. And last, before I conclude, is exposure and environmental control in the whole scenario. That how are you going to control the exposure of the patient? That means, what does it mean? It means, for example, the patient is lying on the road. Obviously, you not be keeping the patient on the road. You have to bring the patient to a safer area. Or there is there is fire in the building, and the patient is fallen down. So you have to remove that patient away from that area. So that is what we call exposure and environmental control. So if you can control the environment of the periphery of the patient, that is this goal, that what you have to do. So what I have done is, this is not an exact ATLS ACLS sort of thing. It is just a concept, primary concept of the ATLS, BLS and ACLS, which I have condensed so that you take a message from this, that why we are doing, why it's important, and basic reasoning which you have to keep in mind, so that when you are in case of emergency, because these figures, whatever I told you, these are the thing which should go into your mind when you are dealing an emergency patient, because you are not doing a specifically well planned elective patient. These are all emergency cases. So in emergency situation, you should have these things embedded into the mind and proceed to a patient, so that it helps to give you a logical sequence, and that's how you're going to deal with an emergency. Well, we can think of extremity trauma does occur. I'll go very fast with this, because we have nothing much to say on this extremity trauma. Only thing that what we are going to do, because major blood loss takes place, does happen in extremity trauma. TB and fibula, it's 1.5 unit of blood is lost, and in case of femur, 3 units, and pelvis is 6 units. So whenever you suspect a fracture of these things, so consider transfusing at these ratios. Particular point of interest in this category is for impaired distal limb perfusion. There impairment in distal limb perfusion. Traumatic amputation can happen. That can usually happens in industrial trauma or a big blow trauma to the legs and hands, and there can be compartment syndromes. So when you see a grossly deformed limbs, what the very first thing you have to do is make it straight. That's what it's orthopedics make it straight. So, and that is that thing which you should have already done in the circulation part. That is the control of circulation, because the perfusion, if the leg is broken, and if you're not kept it straight during the time of circulatory phase of your assessment, then it means that you have not done that step properly. So part of the circulation control, so is in the primary survey. It's already in the primary survey. So you are in that case now, but now in the secondary survey, what you're going to do, you're going to place a traction. You put a traction during the secondary survey. Then consider splinting. Splinting will be very, very important. You can consider thermosplint, and because they achieve traction quickly and effectively. Perfusion to the limbs, they are re-established by a combination of limb traction and the repletion of intravascular valve. The two important things: limb traction and repletion of intravascular volume. The perfusion can be controlled. Remember, this is very important. Two important factors. So the limb traction is very important. Patient now after this, you see the patient is stable. Then send the patient for arterial imaging studies, and finally refer the patient to a vascular surgeon. But the important first step is a local pressure. You just give a local pressure, keep it compressed, and try to control the bleeding. What happens if you find an amputated hand, leg, fingers, limbs? What do you do? Any transected blood, just clean it with sterile thing, with normal saline, wrap it in a sterile towel moistened with normal saline, and keep it in a sealed plastic bag in a crushed ice container, and put it in an ice container. And if you do it, and if you follow this technique, then you will be able to keep that limb viable for the next 18 hours. But if you do not keep that limb, in that way, keep in ice. Then what happens if you keep it in room temperature? It will be only there stay for 6 hours only. So the goal is if any amputated body part is there, try to conserve in ice. That's very important. You get time. The window period increases. Also, administered tetanus toxide is important, and appropriate antibiotics are very important, necessary. Now, how are you going to understand the patient is having suffering compartment syndrome? Because hands and legs, they have compartments. So when the patient tries to move their limb, if there's pain, obviously get to understand, infer that the person is having a compartment syndrome or a decreased sensation of it. If there is loss of sensation or decreased sensation affected part, then think there's a compartment syndrome. And if there is the swelling or paralysis is there, then also think there is compartment syndrome. I have summarized in very short way because nothing much to do, only to diagnose, understand, recognize, and act. This is the part of the primary and the secondary things that you are going to do in case of trauma. But whenever the compartment syndrome, when there's tense swelling with paralysis and these things happen precipitated, fasciotomy is the main thing that you have to do. So, a lot of things to say, but for this time, for this session, I think this much is enough for all of you, because what I wanted to conclude, what I wanted to say exactly to all of you, that when you are dealing in an emergency situation, you don't need to sit out with big fact books and finding out solution for the patient. When you're in an emergency situation, you need to act prompt. You need to have certain concepts, and you need, third important thing is you need to follow certain protocols. What I have told you in this thing is not protocols, is components of the protocol that you have to keep in mind, the logic behind it, the basic analysis behind it, so that you are able to take fast decision in those scenarios. Rest, to act prompt, to act initially in the primary and the secondary survey, you must understand BLS, you must understand ACLS, you must be able to you must also understand ATLS, which we'll cover some other time. But for this thing, initial maxillofacial trauma, this is what I can summarize for you. I hopefully it will help you. So I will pass on the thing to Sayantan. Before I pass on to Sayantan, I thank everybody. You have been a part. There was a technical glitch in between, and probably Dr. Chhetri's lecture we had to abandon it because you all were having a problem with the whiteboard. Maybe we will arrange something better the next lecture. But anyway, technical glitches is beyond our doctor's scenario. And we actually, I'm not a very technical person. That is my fallacy. So next time, Sayantan will be helping us in solving this problem.
Yes.
I hope you all have enjoyed it, and I'll be asking questions. MCQs will be asked from this presentation. Whatever I have talked on these things only, the multiple choice questions will be asked. You'll be given 20 questions, multiple choice questions, in your before the start of the next session next week. So you'll get only 15 minutes to answer. You'll get only, I repeat, you'll get only 15 minutes to answer 20 questions, and you have to score at least 15 answers correctly. That is, you have to score 75% will be the passing mark before you go to the next part, because we'll be doing it in a full-fledged course so that you understand maxillofacial trauma, craniofacial injuries, head and neck injuries, and the management. This was the basic introduction to trauma overall in general. So that's over from my side. Sayantan, this is up to you.
Yes. Thank you, sir, for this lovely session. So I hope, guys, you loved it all, and we will be again meeting next week, Thursday at 6 p.m. same time. If any changes occur, that will be informed. So just revise the topics. Okay, those who are in current year, fourth year and third year students, and all other. Okay, I hope that yes, there are many technical glitches from our side also. So I will personally look into that so that in the next session we will be with a better options. So I hope it's clear to everyone. So guys, please, if you attend all the four session completely, then only you are eligible for the membership. Okay. So like if you just skip one, then it will be not working. So I hope that we will be meeting in the next session. Thank you. Thank you, sir.
Uh,
Thank you.